We're going to just give him. Okay, it looks like we're all set, so please welcome Dr. Thomas Odorizio.
Thank you very much. Lower the lights.
Yes.
Okay. Thank you very, very much. This is an honor and a pleasure to be here. I really, really look forward to these the CCAN talks. I'm finding myself a little bit becoming more of an East Lotto in the Midwest. I have 6 clinics a week dedicated to the neuroendocrine tumors, and the more I look around in the Holden Comprehensive Cancer Center, the more I find myself, by myself. It's kind of an interesting phenomenon. But I share 2 clinics back to back with our general endocrine surgeon, our neuroendocrine surgeon, Jim Howe, and 3 clinics in the hospital with our medical oncologist, and then 1 clinic with medical oncology in the VA. So I'm asking them if they would to just turn the lights down. I really need that because these are AT&T slides. I was promised that when the lights would go down, that these slides would reach out and touch the audience. That's the truth. And when I got the bill, it reached out, I got kissed on a few of those things. I'm just telling you, yes, yes. So here we go. I think, can we get them down?
Working on it now.
Okay, we'll go ahead and get started.
In the world, everything is ruled by computers.
That's right. So in your handout is the schema that we use, and you've heard a lot about the approach, the different options today. And we heard about from Dr. Gerstein, the time to progression, the average time to progression. The way I talk about it is overall survival is equal to the sum of the times to progression. And so what I added for you on this particular slide is the time to progression with each of the options. And I would just merely say that every option is a good option, but the good option at the wrong time isn't your best option. And that's what you've heard time and time again this morning, Dr. Labudi and Dr. Liu. You have to know, or the team needs to help you, the managers of these clinics need to be able to help you with the right option at the right time. And that, because you always, I'm finding, you always give up a little bit with procedures maybe in the liver, and you don't want to shut one door in pursuing another door. And those are very fine-tuned things that come from a whole lot of experience and the people that you've heard today thinking about it. But one of the things I'm going to share with you today is the theranostics. The option of theranostics, which is also called peptide receptor radionuclide therapy, which I will share with you, which has been in Europe since 1996. It is here now in the United States as a registration trial for mid-gut tumors. And it is hoped that this trial, approved by the FDA to have an arm of 60 milligrams in one group and 4 therapies with the lutetium-177 PRRNT, will lead to ultimate registration in the United States. And while Dr. Gerstein worried when he talked about putting PRRNT way up at the top, that's the first time I've ever seen it there, and although he had it next to palliative, and unfortunately in endocrinology and even endo-oncology, I don't know the word very well. And it's because I don't see that like Dr. Gerstein sees. But if you see mine, I dotted that line only one time from surgery down to PRRNT. And when I dotted it, Dr. Richard Baum from Bad Berka jumped all over me, and he's much taller, big German, and I wasn't going to argue with him. So I went back and I thought about it for 5 seconds, and I made the line solid, because in 5 years, it's exactly what Dr. Gerstein suggested. It won't have palliative. It's going to be treatment for neuroendocrine tumors exactly like thyroid cancer has been treated since 1933 for thyroid cancer. You cut the tumor out, You do a thyroidectomy, and you give them a swish and swallow with radioactive I-131, and you say, come back and see me in about 5 years. And that's exactly what's going to happen when PRRT is approved by the FDA. You're going to have initial surgery, and then you're going to have a course of therapy either with lutetium PRRNT or with yttrium-90. And what I want to share with you is the news of where we've come since LSU and Dr. Woldering and CCAN's meeting, because we now have theranostics in the United States, both at Vanderbilt and Iowa. And theranostics is just a term that talks about using the same carrier to make the diagnosis with gallium, and then taking the gallium out of the carrier, a modified octreotide, and putting in radioactive yttrium or radioactive lutetium. And that is theranostics. So I'm going to spend a few minutes talking about the gallium-68, the very subtle differences between one form of octreotide carrier and the other form of octreotide carrier. It makes no difference, literally. And then show you how when they attach it, I'll show you just one piece of the PRRT therapy that we looked at recently. It's in abstract form. And I think it makes the point that Dr. Gerstein showed initially, and as far as I know, the only place it's been shown, namely that it makes a great deal of sense to move the PRRT up very high in the options of care. So here's the schema. We do everything pretty much the same. I'm a big proponent of octreotide. You can see gallium-68 now is way up at the top. Pretty soon it'll be above Octreoscan, as it will replace the Octreoscan, and I'll show you, and you will see why in a few moments. We have a large neuroendocrine tumor database registry. We presently have 1,600 people entered into the registry. The registry allows us to keep folks in line for new options of care as they come along. And we have the traditional surgery by a very expert person, not unlike Dr. Liu, Dr. Jim Howe. We have hepatic arterial embolization procedures. Dr. Gerstein alluded to the anti-angiogenics. The anti-angiogenics don't look very good from a time to progression of 7 months, but they are very valuable, clearly, when they're used at the appropriate time. I have one from the original RAD 001 that's now almost 4 years with a huge tumor, neuroendocrine tumor of the pancreas. It hasn't budged. It's been through the stomach. The tumor went through the stomach and it's just been sitting there, and it has not progressed at all. So when you look at time to progression, you have to think, yes, it's 50, time to progression, 50% of the folks progress, but you have that other 50% that may go very long periods of time. And then you have the PRRT, which comes straight down from the surgery, conventional chemo. But I think there's a huge role in terms of the medical oncology, because you can just about divide. You could take from the top, and you could take medical oncology straight, learned neuroendocrine medical oncology, and take it straight down, and they oversee. They oversee hepatic, at our place, in most places, hepatic arterial embolization is oversighted by medical oncology. The clinical trials with everolimus are oversighted by medical oncology. Conventional chemotherapy is oversighted by medical oncology. And this whole and I'm not sure where liver transplant is ever going to be. I'll be honest there, and we can talk to it. I just don't see that as long as we can keep tumors that live with the liver from becoming too close to the liver, why we can't just keep the liver living. And so I'm not sure that as much as they try to fit liver transplant into neuroendocrine tumors, I'm not sure it'll ever make it. Because you have to have such a score for liver failure, you never make it, because your liver function studies are normal until 90% of your liver is replaced. And for maybe the neuroendocrinology oncologist, if you will, we can come straight down and kind of work with nuclear medicine closely for the PRRNT, clearly work with our surgeon closely in helping with the diagnosis. But the board's really kind of divided, and gastroenterology certainly on the left side with us, and you can really divide that schema into two pieces. Now, in terms of contrasting Octreoscan and Dtpa, or the PET scan, the gallium, this is a very rough comparison, not very rough, it's pretty precise actually, but it does tell you some of the differences between the Octreoscan, which we had in the United States. We were the last country in the world to get Octreoscan, June 8th, 1994. I fell to my knees. I was so excited. It finally came here. But every country in the world had it before we did. And it was a very good functional test for the neuroendocrine tumors. But if you see the resolution of an Octreoscan, that is how refined, how precise do you see a tumor with an Octreoscan, and that's because of the nature of the indium-111, which is SPECT imaging. It's only 10 to 15 millimeters. Sometimes in the lung with a double kit, you could get down to 7 or 8 millimeters, but that was a lot of money to spend. The gallium-68 is a PET scan, positron emission tomography, and the level of resolution is 4 millimeters. 1 inch is 25 millimeters. This can see down to 4 millimeters. This thing is as close to reading your thoughts as I've ever seen. So then they talk about binding affinity. When you talk about binding affinity, that means how good does the carrier, the octreotide, bind to the somatostatin receptor subtype 2. These tumors are all about one of 5 somatostatin receptors, receptor subtype 2. They all possess receptor subtype 2, some less, most more. Over 92% possess that. Because of that receptor, we can exploit it. And octreotide was the mimetic, the look-alike hormone of somatostatin that precisely took a piece of somatostatin God made and was able to make it do the same thing that native somatostatin does in a longer period of time. 22, that's a term for its affinity. The higher the number, the worse the binding, versus 2.5 when you talk about the DOTA gallium test. So exquisitely small amounts of this material carrying an image maker can bind to a tumor at 0.4 versus 22.3 or 22. The thing you need to also remember is that the radiation dose per patient, take a look, in terms of the nuclear medicine speak, and this is as close as I'll get to it, is 2.6 rem. Now, you know that number is a lot of rem versus 0.4 rem. That's a radiation number. So 1/6 of the radiation is involved with the gallium versus the Octreoscan. And the convenience is most of you in the room have probably had at least one Octreoscan, and the time it takes is a minimum of an injection, a 3-hour and a 24-hour scan. Some say we want to go 48 hours. By 72 hours, you're wondering why you're going back. It takes anywhere from 40 to 50 minutes to acquire the information for the gallium PET. There is no downside to the gallium PET scan. Like I said, they had it done. They do about 8,000 to 10,000 gallium scans in Europe a year. And it's staggering that with all of the galliums that were done in Europe, the FDA took one look at all the information garnered from their gallium PET scans in Europe since 1997, and they said, we can't use one piece of information from it. So they rejected every single scan that was presented in summary to the FDA. And the reason is they didn't have SOAP, S-O-P, standard of procedure. And because we don't have standard of procedure, we have to do what Vanderbilt and Dr. Liu did and what Dr. Sue Odorizio did for us, and that is she applied for an investigator's new drug, and in the process of getting the investigator new drug, the FDA allowed us to have cost recovery, and because of that, we are able to tap insurances for the cost of that. And the cost, by the way, is about 1/2 of what an Octreoscan is. This on the top is the Dtpa Octreotide. So think of Dtpa and DOTA as a tiny little cage attached to the rear end of the octreotide. And in that cage, you can put indium-111, and you have an Octreoscan, or you can put gallium-68 in the DOTA, and now you have a gallium-68 DOTA modified octreotide PET scan, positron emission tomography. And you can see that virtually knowing the structure, if you know the structure of octreotide, with the exception of one substitution where you see the phenylalanine for the octreotide, the one we use is a tyrosine. The one Dr. Liu uses, the rear end of the threonenolol fell off, and they amidated it, and it's called TATE, T-A-T-E. But it's virtually the same compound as the TOC, T-O-C, which is what we use, but they're both octreotide derivatives. Now, just two little studies for you that did come from Europe, small studies but important studies, because one of them went against Octreoscan toe-to-toe to show the differences between. This first one is by Gabriel, and what they did, and you have it there, and you have the references if you wish to look them up, but it looked at a comparison between the Octreoscan and with the CT included with it, the regular CAT scan. They had 84 patients. They had 3 groups. There are 3 reasons for looking at those were the detection of unknown primaries, clinical or biochemical suspicion. They only had 13 patients. They had the initial tumor staging, N is 36, which both Eric and our group, Vanderbilt and our group, use it for that quite a bit, and decision-making, which has changed dramatically with the gallium, and the post-therapy follow-up. So we do it for pre-PRRNT. The FDA gave permission to do 2 more after PRRNT to see if functionally the PRRNT worked. The gallium is so good, it quantitates how well the response will be with PRRNT. What they divided the groups into true positive, true negative, false positive, and false negative. And these were based, and this is a quote right out of the paper, all were based on all available histologic imaging and follow-up findings. So in there was a little kind of a black box, and all we have to do in the paper is say, oh, they've been following these patients close, they gathered the information, but they never break it down. But the results were staggering. In that small group, they showed that 97% sensitivity. That means it's sensitive to and precise for a neuroendocrine tumor, but sensitive to pick it up down to 4 millimeters. It was specific 92% of the time, and the accuracy was 96% with the gallium. Pardon? Oh, sir, do you have a question back? Oh, I apologize. Their conclusion was that the gallium showed a significantly higher detection rate compared with the conventional somatostatin Octreoscan, and also the diagnostic CT scan, which is what we talked about today as the gold standard. You need, as Dr. Labudi said, you need anatomical decisions for the most part before you, anatomy, before you make a decision or a contemplation to do surgery. This next paper looked at the 2 different kinds of gallium. And what I'm going to say is a very small change between the 2 of them. We, for the most part, in the United States, we have both the one modification one called the TOC, and the one that Vanderbilt uses, and the one I think is being used at Excel Diagnostics pre-lutetium therapy there, Abe Delpassant, is also the TATE, T-A-T-E, and that's the piece that fell off at the back. And I think we're the only ones right now doing the TOC one, but it's just a minor variation on the octreotide carrier, very small. But I thought it was interesting. They looked at 40 patients with these tumors. They did both a gallium TOC and a gallium TATE PET scan. They were both positive emitter tomography. And they compared the marker lesions that they had. In other words, you need a CT scan to show anatomically that it's a nickel, dime, or quarter that is lighting up. Nuclear medicine sees things that shine. It doesn't see things that give dimension. Although they tried to read it, you need the CT scan for it. And the most important marker that came out, the most important number that came out of there was called the max standard uptake value. And that's max SUV. And that's a quantitative value that comes from the positron emission from the tumor given off by the gallium-68. And they did note that there might be a fewer lesions with the TATE PET than with the gallium TOC PET. But as you can see, those numbers, they're very, very narrow. And that they show that the gallium TATE may have had the SUV values might have been a little bit greater with the TOC PET versus the TATE. Given all that, they said no difference between the sensitivity, no difference between the quality of the scan. So wherever you go, when you get the opportunity to have these in the United States, both are very, very much the same, and both give you critical information for quantitation of the tumor. It says, how good will I do when I get my lutetium therapy or my yttrium therapy, and it'll predict very precisely the kill. And that number is not well known yet for the max SUV, but it seems to be around greater than 3 to 4. So any lesion that's greater than 3 to 4 max SUV will probably render you eligible for therapy. So their conclusion was just as I said. Maybe the gallium TOC is a hair better because the material goes inside the cell a little better than the TATE, but that's small. The bottom line is what it is, and that is you have it on your sheet because they compare, they're very comparable in the quality. Now, we did a study, the first study we did, and I'm going to show you the actual images of the Octreoscan and the gallium of the 5 patients. We took 5 patients, we counted up about 47 lesions total, and we did a repeat gallium. We asked the simple question, if I did a gallium on any one of you this week, what happens if I bring you back 1 week later and do the same test, the same gallium? How reproducible are those 2 tests? Now, that's pretty important when you think about it. Because you go and have PRRT, and then you come back, and then you have another, let's say you had a gallium before and a gallium after, and you don't know if it's significant or not, if there's less uptake. And so we just wanted to know, what is that error between 2 of in the same patient? That was a simple question we asked. So we had 5 subjects with metastatic documented neuroendocrine tumors. We studied them twice within a week apart. We looked at the maximum standard uptake value between the 2. And as you know, the SUVs are quantitative. So the intra-class between the same subject, 2 different gallium TOC, DOTA-TOC PET scans, the correlation coefficient was 0.99. Now that would be, in terminology, tighter than a frog's rear end. And that is watertight. I'm just telling you, just in case that, if the more close you are to 1, the better you are. The max SUV between the two scans, counted separately, did not differ by more than 25%. So that if you go to Bod Burka, and they do a Gallium-68, and we just did this with a Bod Burka Gallium, and they send us the CD, and we can quantitate what the lesions were before the treatment with PRRT, and then we did a Gallium-68 on the same patient, which we did. We could tell outside of 25% that there was a change, either more uptake or less uptake. And in the 3 that have been done in Bod Burka that gave us the Gallium-68s, that we then did one after treatment, the change was in all 3 of them greater than 50%. There was no doubt that the Gallium-68 predicted and showed a very effective response. And that's the conclusion, namely the difference of more than 25% in the SUVs between the two scans reflect an important change in the biological character of the tumor. Remember, this is a functional scan. Dr. Warner this morning referred to the FDG PET as talking about activity. This is actually a functional scan for how the receptors, how the tumors are behaving. Now I'm just going to show you. Perfect. This is exactly where we are. Good, thank you. That's the problem. You know, I get this self-righteous rhetoric. You can hear it. And I almost, this morning when Dr. Gerstein gave me the opportunity to disagree with him, you know, I was reminded of that National Geographic thing the other night where the sea otter is going down the spillway, cracking a shell with a little tiny erection yelling, "Raise the drawbridge." I said, you know, you got to stay modest on this. I'm sorry. So here so all 5 patients now, here on your left and on your right is the same patient with an Octreotide scan and the gallium on the right. Honestly, I looked at these things again last night, and looking at the Octreotide scan is like looking through the cataract in my left eye. I mean, that's the way it is. And you can see it. I don't have to say anything about them, just look at them. And you can see the detail, the definition. Now, some people, and I warn people, and I'm sure Dr. Liu does as well, you may see things, they may find things you did not know you had. And that is not the intent, to find another Ditzel. It is not our intent to do that. The intent is driven to, do we know where the primary is? On these, we knew where they were. They've all been taken out. These are metastatic tumors. They were all quantitated. And these are the patients that were repeated that gave us the information we needed. There again is another patient, left, right. It was a gastronoma patient who had a remarkable response to PRRT, is now almost 2.5 years with absolutely no progression. And you can again see it. And there on this, again, you can see this was on the left, and then on the right, that would be terribly frightening. My God, you mean I have it in my bones. And the point is that everything that's seen by the gallium will be targeted by the PRRT. That's the magnificentness of this test. And this is the patient 3, and you can again see patient 4. And these are the best pictures at 24-hour planar that you can have. These were not, this is the best the SPECT imaging the Octreotide scan could give. And that's the gallium that was done at 50 minutes acquisition. Oops, what happened? Oh, I must have been, sorry, I'm going back and forth. You're going to go crazy here with me. And now this one was a trickier one because we didn't have we suspected it was midgut, and that's the Octreotide scan on the left. And on the right, you can see the gallium up there. You can see the spot developing under the right side of the liver. And there it is. And on Octreotide scan, if you go backwards, they said, oh, yeah, there it is. It's really there. But only when they saw it on the gallium did they go back and find it on the Octreotide scan. Now, This is the safety and efficacy that both Vanderbilt and we both got our INDs in part. How safe is the scan? And this is actually through January. And this is the paper that, this is the study that we're going to show you just to give you a quick overview. This was a written informed consent. Vitals were done, chemistries were done. Between August 1st and January 24th of 2013, 36 scans were performed. No adverse effects. There was virtually no side effects or untoward events. 19 unknown tumors have been identified to date, which is about 85%. These are people with known metastatic disease. In terms of primaries were not found, and in every single patient, surgery was done, and would not have been done without it. So the advantages of the gallium is the 3 to 5-4 more sensitive than the Octreoscan, lower radiation, single visit PET versus multi-visit SPECT, which is Octreoscan, superior to FDG PET for the brain, and precisely predicts response to PRRT. And I'll just move fast. This is another patient with an unknown primary, and you can see the arrow just went up there on it. And again, this is just more of the same, and they were able to get it. Thus far, we believe the gallium can improve average time to progression by knowing beforehand what the lesions are. For instance, beginning higher dose sandostatin or beginning sandostatin period, prevent ineffective therapy such as PRRT if the uptake is not high enough, and even radiofrequency ablation, and optimize the next best therapeutic option. This one is the new study we have. It's the second IND. We've been allowed to look at a patient who is now stable with known disease. We can offer the gallium-68 now and in 6 months at no charge. And you have to have stable disease. I was told I could tell you about this. You have to be stable. And with known lesions, we could give you the gallium. You have to have an Octreoscan done side by side. That one is insurance covered. And then we'll provide the 2 scans for you, one now and one at 6 months. And we're now going toe-to-toe to show the superiority of gallium over Octreoscan. Right now, we don't have the hard information, but we will now. And this is the man responsible for theranostics. At the first Congress, both Dr. Liu and ourselves attended, and probably some others as well. And he's the one that had the first World Congress on theranostics. And theranostics, that's what he said it is, and here's what it is. It's octreotide modified, and in the cage of DOTA, you either put gallium, yttrium, or lutetium. And the Gnostics is the gallium, and the Thera is the lutetium or the yttrium. And that's how it works. You can see that the carrier key is the same. So it happens that this little piece of peptide strung together links at the lysine. So lysine is what fits best into the SST2, very good fit, and then that carries usually inside the cell. It's taken inside the cell and resides there. Here it is again. There's the target tissue on the left. The vector is the octreotide, and the gallium is the diagnostic scan. Is the diagnostic material. Gallium is a PET material. And the only last thing I want to share with you is the outcome of peptide receptor radionuclide therapy in patients that we have had, that we treated at University of Iowa in 2000 and 2001. We did the first Y90 study internationally, and we did 40 patients, 120 treatments, and then the rest we had sent to Basel, Switzerland, the same place. And we wanted to know what happened to those folk who had just one PRRT therapy. So the 108 people that we had, small bowel folks were midgut 44%, pancreas was 28%, lung was 5%. And you can see that most of them were done in Basel, Switzerland, 72%, but we did 26% of the patients there. And you can see most of them had Y90. And the last thing is the table, and you have it there. But the bottom line is OS from diagnosis in years, that's the overall survival for all sites, small bowel, pancreatic, neuroendocrine, and lung all on the left. Overall survival from PRRT, one treatment in months. So small bowel with one treatment at the time they went over with metastatic progressive disease or were treated at Iowa, 96.7 months. PNETs, 39.7 months, and lung, 22.7 months. Those were statistically different, and you can see time to progression from the first PRRT, and that is, again, 5 years with small bowel, just one treatment. PNET, 63 months, another 5 years, and that was alluded to. I think Labuti talked about that this morning when he looked at the curves. And the lung, unfortunately, is still a reflection of where these tumors grow. What you've heard all morning long is it matters where the cell, you turn these cells upside down and these tumors upside down, they all look the same. But where they grow makes all the difference in the world. If it's lung, they behave one way. If it's pancreas, they behave one way, and probably more like the lung. And then the bowel reflects another behavior. But what Thor Halfdanarson said, our medical oncologist, he was the first. It was not Rotterdam. It was Dr. Thor Halfdanarson, medical oncologist, now at Mayo, Arizona. He said, based on these information, it would make sense that the PRRNT should be moved up much higher than at the end. Everybody, I've had people come to me, this is the last step, this is the last thing you can do, PRRT. It's, you know, my eye, I just get hurt because the last thing I want to do is have them think it's the last thing that they are getting in terms of option. It should never be that way. It can't, once the FDA approves it for us, we're golden. We have the Y90, we've gone back, gotten all the INDs. Dr. Sue Otoricio's the alpha pup, no question about it. She has brought the IND for the Y90 DOTA-TOC therapy. We will have it at the University of Iowa on site we're hoping by the end of the summer of 2013. This will be obviously for progressive tumors, not necessarily midgut, but mostly pancreas and lung. And it's going to be a phase 2 study. There will be no control on that. They're all getting the therapy. And so it'll be 3 fractions over 27 weeks. 3 treatments, 9 weeks apart. And we are hopeful that we will be able through CCAN as the time comes. And you can all see it. There's a website I put on the thing for you for the protocols that are available now with the Gallium-68. They're on clinical trials, and you'll see the IND approved for the second Gallium-68. And now we're very, very pleased. And as you all know, the lutetium-177 DOTA-TATE therapy called Lutathera. I guess Dr. Stanley Goldsmith, Dr. Warner told me Stanley Goldsmith has it at Cornell University, is about to start it. It's a very hard study to get up, but once it's up and running, midgut carcinoids will be eligible. That's the Lutathera study for progressive small bowel tumors. And there are 13 centers in the United States partaking. It's very intense because you have a lot of visits to make in the first 24 months, something like 12 to 14 visits back to the center. So I'm hoping you can learn who, and the CCAN could provide through their voice, the centers in the United States that will have the Lutathera up. It's a very important study because it'll be the registration study for which PRRNT will be approved by the FDA in the United States. If we can be of any value or you have questions, but you're most free to just call. Thank you very, very much.